My disclosure is my experience with IABP, decent, experience with ECMO, minimal, and experience with other mechanical cardiac supports, none. So this is a 47 years old male, anterior wall STEMI, diabetic. He was lysed elsewhere and came with acute heart failure. The RC is occluded, LAD has a significant disease, a tight lesion in the LAD. We went ahead with a PCI. First, the IABP was put and 2 deaths in the left anterior descending coronary artery. And we could discharge this patient. You can see, despite all these things, the flow was not that great in the LAD, but he improved and we could discharge after 10 days of the hospital stay. A 68 years old male, anterior wall STEMI, he had VT, shocked and went into complete heart block, put in a TPI, and he was taken up for an PCI with the IABP support. Here also the LAD, we put 2 stents into the LAD. He needed a ventilatory support. He went into acute kidney injury, needed a renal replacement therapy, extubated on day 2, IABP removed on day 3, and he was discharged on day 11. This patient, this happened 2 days ago, 57 years old male. He was admitted in the CVTS for a coronary artery bypass grafting. They sent the patient to us for a re-angio. In fact, immediately after the angiography, the patient developed acute pulmonary edema and he crashed. Since the LAD was diffusely diseased, we thought if we can keep the patient alive with a massage and other support, we may go and fix up the right coronary artery. So you can see on massage, we wired the RCA and ballooned the RCA, followed by a stent in the RCA. We didn't do the stent in the distal RCA. We did a POBA to the distal RCA, put on ventilator support, TPI, and intra-aortic balloon pulsation. So then, since the patient did well afterwards in the thoracic surgery, we recalled the patient back and completed the procedure, complete the revascularization. You can see the LAD distal, it is diffusely diseased, but the proximal area we stented and the distal RC also stented. Whatever is possible, whatever complete revascularization is possible with PTCA, we could provide with the support on IABP, and the patient is still today on IABP. And I'm sure this guy would not have survived till now without this support. So IABP long, it's a device of long stanting. First used in 1967, with a moderate LV unloading, increases the cardiac output, but the cardiac output increase is close to 1 liter per minute, 1 liter per minute. It can increase the mean arterial blood pressure, it decreases the LVEDP, decreases the wall stress, and decreases the myocardial oxygen demand. But you can see when compared to the microaxial flow pumps or tandem heart or a peripheral ECMO, you can see the increase in the cardiac output and the unloading is not great when compared to other things. It gives a minimal one, but sometimes this is sufficient to support the life of a patient. The BCIS-1 study, elective IABP has been found to improve the long-term survival after a high-risk PCI. Most important thing here is the 50% of the planned IABP was before PCI, and 50% there was no planned IABP before PCI, of which 12% required bailout IABP. And there was a decrease in the mortality in this particular study. And this study actually took away the charm of IABP, because till that time, every high-risk patients or CHIP patients, we used to put IABP or at least consider IABP in our mind, primary PCI with shock and other things, it's a routine IABP. Then after this trial, which came a little long way back, 2014, largest trial in IABP, 600 patients with cardiogenic shock. But you can see it was between 2009 June and 2012 March. 37 clinical sites in Germany, 301 patients randomized to IABP, 299 randomized to the control, and with a 30-day follow-up, close to 300 and 298 in the control arm. No difference between the control and the IABP arm. The strength of this trial, biggest randomized shock trial, 600 patients included within 32 months, and in 2009 to 2012, the contemporary treatment for cardiogenic shock, that is more than 95% underwent revascularization and follow-up close to 100%. But limitations, it was underpowered for the primary endpoint and no hemodynamic shock assessment, and 10% crossover to the IABP arm, and 83% of the patients received IABP post-PCI. That's the most important thing. That is what we have learned from our experience also. If we want to put in the IABP, better put in the IABP and go ahead with the procedure rather than wait for the procedure and then go ahead going with the IABP. This single center observational study, only 102 patients, they looked at the mortality, MACE and the renal failure. If IABP was put before PCI versus IABP after the PCI, there was a significant improvement in the mortality if IABP was put before the PCI. You can see the MACE rate, there was a significant benefit, statistically significant reduction in the MACE rate when IABP was used prior to the PCI. And the CRISP AMI sub-study, intra-aortic balloon counterpulsation reduces mortality in large anterior wall myocardial infarction complicated by persistent ischemia. That is a ST elevation persist more than 15 millimeter and persisting, and there was no resolution less than 50% after the revascularization. Continuing the IABP, putting the patient on IABP and continuing the IABP, there it reduced the mortality. And this is one thing that is coming up. Outcomes of veno-arterial extracorporeal membrane oxygenation plus intra-aortic balloon pumping for treatment of acute myocardial infarction complicated by the cardiogenic shock. You can see in the VA ECMO plus IABP versus the VA ECMO alone, there was a benefit in terms of mortality reduction. So before the propensity matching and after the propensity matching, you can look into the B, there is a benefit which is offered by IABP for a ventricular unloading along with the veno-arterial ECMO, a 30-day mortality was reduced. So this, certain people believe, many people now believe that though IABP is, Europeans say it's a class 3 indication, that's a contraindication, this may be the last remaining indication for cardiogenic shock in the Western world, IABP for the left ventricular unloading in veno-arterial extracorporeal membrane oxygenation. So if you compare ECMO, tandem heart, IABP, IABP seems to be a, what you call, a primitive thing. But we don't require surgical axis repair for IABP. Vascular axis point, you may require multiple axis points in the ECMO, tandem heart, but you need only a single one in the IABP. Catheter and the cannula size, normal catheter size, 7 or 8 French, transeptal puncture is not required. Physiological timing, of course, so in arrhythmias, there may be a problem, patient who has arrhythmias. In sinus rhythm, it is better. Bleeding risk, not that great. Hemolysis, of course, is there, but limb ischemia, when compared to the tandem heart or Impella, it is less. And the most important thing, cost and availability, there is no comparison. We have IABP everywhere, the cost is too low when compared to the prohibitive cost of Impella and other things. So, this is an easy one, friendly one, widely available. We are all familiar with it and really cheap. And the only available mechanical cardiac support for more than 95% of the Indian operators. So IABP utility in cheap. This is the only mechanical cardiac support available to majority of operators in India. And we are all familiar with this device. And experience vouches the benefit, though data do not favor its routine use. And I believe still it has a role in chip. Thank you so much.
Question?
So, excellent talk, Dr. Jabir. Just one little, point. Use of IBP in shock is different from use of IBP in chip, which is actually protected PCI. All the trials of IABP have been which got a bad name or it didn't show any benefit was actually those patients who are already in cardiogenic shock. And protected PCI is, I think, slightly different subset. The problem with the ECMO is it actually raises the LV EDP a little higher. So in patients who have got LV dysfunction and who have got bad LVs, putting an ECMO alone actually doesn't solve the problem. It's more useful for protecting kidneys and the brain in a patient in whom you need a long procedure and you're worried about the pressures and you're worried about vital organ perfusion. So the basic conceptual difference in the use in protected PCI, in shock, and in patients who have got vital organ hypoperfusion but still almost preserved LV. For protected PCI, it gives a LV of additional cardiac output of approximately 0.5 liters with a little bit of unloading of the LV. But it hasn't been subjected to large randomized trials as yet. So I think we are a little short of data there. Until then, we just continue to use this.
We don't have a data. But as you rightly pointed out, in a VA ECMO, if we can unload the ventricle with a IABP,
Yeah,
Of course,
but it doesn't. It's not all that great actually.
It's
You know,
may
but
not
it's
be
still-
all-
It's better. It's better.
that
than
is
nothing.
where
But
some-
the one statement which you made, which I really liked, that you said 95%. I will say 99% of operators in India do not have access to MCS.
Right.
So
I was a
Exactly, I
little
think.
modest. At least many of us dream to put a impeller, but most of the time I don't think whether it is possible or not.
Jabir, as usual, it's a wonderful talk.
Yeah.
Well, anyway, with cardiogenic shock, the cases that you showed, you would invariably have an IABP going in simultaneously. Probably one might be operating on one groin and the other operator would be putting in an IABP on the other side. Now, with respect to these chip cases, what is your practice? If at all you're planning to put in an IABP, you would always want to have the IABP implanted first and do the chip, or would you
First.
have a 5 French sheath on the other side, wait for hemodynamics? If the hemodynamics it gets down, probably would that be the situation wherein you would put in
If we want to use IABP, what the data is, as you said, it's more from the primary PCI, the shocks, but it's always better to have the IABP in place and go ahead with the procedure. And we can remove the IABP very, very quickly. Once the hemodynamic stabilizes, even after 6 hours or 12 hours, we can pull the
Dr.
IABP.
Daughter, your comments on?
I mean, talking on this topic, if it is elective, let's say left main to LAD rota PCI with low ejection fraction, patient is well compensated. I try to do a quick procedure through the radial axis, and patients can sit up in the end if they start to develop symptoms. But of course, putting a 4 French femoral sheath in the groin with ultrasound access also makes me more comfortable in more difficult situations to try to avoid upfront. But yes, there are some situations where I would put a balloon pump up front. And in my practice, 90% of the time, unless the patient is really obese, I do it sheathless approach. So on the skin, it's only 6 French hole. Removing that after 2-3 days in CCU also not a big deal. My question to the audience, of course I know it's doable through the brachial or through the axillary access, obviously probably easy from brachial with sheath. Do you do that sometimes when there is no availability of groin access with severe peripheral disease?
Still, we go for the groin axis, and if there is a no groin axis, I have not tried it
I
yet.
think
the
some
axillary
people have used brachial.
If
axillary
axillary
axis.
artery.
It's there, axillary
Yes,
axis.
Rashid.
Would LV EDP measurement or PA or capillary wedge measurement before starting a chip procedure, would it make a difference, and would it change your decision to put a mechanical circulatory support device?
It's very difficult because whether we do not know whether it's going to help. Then we have to check it after putting whether with mechanical cardiac support or without mechanical cardiac support, whether the pulmonary venous congestion is less or not.
I think all of us would agree that in most of our cath lab crashes, in elective PCI, IABP has definitely helped and turned the procedure in our favor. That's what I have felt. But once the patient is in metabolic acidosis, either because of STEMI with cardiogenic shock, high lactate levels, then IABP doesn't work. So I think, as Jabir said, it has to be upfront usage.
Once the patient is in an irreparable state, then
No,
there
but
is no
cath
point.
lab crashes,
That's
I
no
have
point.
definitely it salvages the patient. I don't know, what do you think, Dr. Ronnie?
please come. Just one point. I would always do a right heart cath and make the decision as to I'm going to put the IBP up front or not. And procedural complexity also helps, obviously.
How does it guide? Could you tell me what protocol do you use?
I think that what he said is a very important point, because, previously when we used to do PAMI in the early 90s, used to always put a PA catheter. So the PA catheter, the PA pressures were high, it used to tell us that, this guy is going to be bad and you got to be careful. So a lot of people still go and would put an IABP if your PA pressures are very high. But I think the problem is we hardly do a PA right heart cath now. Venous line is never taken. So that's a problem with the PA line right now. And madam, I think to what that question that you asked, I think what Jabir said is very, very important. I think if we're deciding to go with an IABP, I think it's always better to go in early.
Go up front. Yeah.
But when you don't need an IABP and you decide you're going to do a PCI, and when you have a crash, I think obviously IABP helps. But in those circumstances when there's really a crash, if you have an access to a VA ECMO, that I think saves their life.
And left heart cath, instead of doing a right heart cath, you can slip your catheter into the LV and get the LV EDP. Isn't it? Is that possible? So you easily get the LV EDP from
Most of the information is available on echo.
Yeah, you see,
LVDP,
you
pulmonary
need to know what the
everything is
RV
available
function
on
is as well. So ideally, you should take an RA, a PA wedge.
What type of patients
and
do
an
you
LVD.
do right heart cath for your
Any patient
patients?
with LV
CHIP
dysfunction
PCI
for-
or?
Yeah, that's what we discussed it in the morning, I think.
Yeah.
Any patient with LV dysfunction for whom you could
Honestly, we have not done it so far.
It's
I
not
have
very
to-
difficult. It's very, very simple, and it gives you very, very good information as to how your patient is going to behave on the table. It makes the procedure extremely safe. It tells you what you need to do before, how long you can work. We use the PA catheter, as I said in the morning, for giving drugs as well. We use low-dose NTG and milrinone in patients in whom PA pressures are high. It extends the time when the patient is going to crash. Instead of trying to run when everything is already fallen, you plan for it before and you know what you're doing. You can actually see what happens to the PA pressures when you're inflating balloons in the left mains, etc. It gives you minute to minute, second to second, kind of monitoring. It's extremely useful, and it's very, very good in centers where things like Impella and all are not really available all the while.
So does it help you choose your device?
No, if you are in the best of the centers and you know what is right ventricle, I think it is extremely important to know about the RA, RV and PA. In fact, PAPI. Everybody should know what is PAPI. And if you're doing cheap CTOs, you want to learn about the hemodynamics and you don't know about PAPI, I think you're understanding half of the hemodynamics. Half of the patient will die because of RV. Second thing, I'll take a step beyond. Today you have PA catheters which will tell you pressures. I think it just doesn't add as much as we need. What we really need is, like you have a pulse ox which keeps telling you what is the saturation in the systemic arteries. If you have a PA catheter, you don't have the technologies today. If you have a PA catheter which keeps telling you what is a mixed venous saturation, it will tell you much before you really need a good hemodynamic support. See, many of the times you find now your patient is crashing. Well, I'll concur with what Ronnie said, that if you are in a real crash situation, maybe IABP will not help you. In that situation, you need to support the circulation fully. But not uncommonly, you are into a difficult situation much before you realize that you have really gotten into trouble. If you have a PA saturation which tells you that your systemic saturation is good, your pressures are good, your heart rate is good, but your PA sats are going down, which is telling you that your cardiac output is going down. In fact, that may be the early time to intervene. Unfortunately, we do not have sensors in the PA.
Yeah, I think it has been an exciting talk. I think
One more.
last comment.
Yeah,
Discuss.
just a newer parameter that has come up is that the lactate levels from the coronary sinus.
Yes.
That also gives a good indicator of the need for a mechanical circulatory support.